Good morning, everyone. Thank you for joining us today. Today, we are joined by Katie Cordes from the American Heart Association to talk about the Rural Healthcare Outcomes Accelerator program. I actually met Katie last month in Kansas City at the National Rural Health Association's Critical Access Hospital Conference. And she was sharing information about her program that she's going to share with us today. And I thought this is really cool, and this would be something our hospitals could definitely utilize and take advantage of. And so Katie's going to go over, I sent out the flyer earlier, but she's going to go over the program and then answer any questions you might have. So Katie, I'll turn it over to you.
Okay, thank you so much. I'm Katie Cordes. I'm the Senior Manager of our Rural Quality Improvement Programs at the American Heart Association. Very excited to share with you today a little bit of information about our Rural Healthcare Outcomes Accelerator that we just launched very recently. And what we're really doing is launching this program in an effort to really equitably address the needs of our acute care hospitals in rural America. A large, kind of impetus for this was our call to action rural health presidential advisory that we published in February of 2020. A big portion of that really reviewed the fact that there's an ongoing and actually increasing disparity in health outcomes in rural versus urban areas. Here at the American Heart Association, we really strongly believe that it shouldn't matter where you live, if you live or if you live well. So we really wanted to be able to, kind of in light of this, that it is, leveling off in rural areas where it continues to decrease in urban areas. We wanted to be able to come up with a solution. There's certainly many factors that go into why those outcomes, are disparate, but we wanted to be able to provide additional support to our acute care facilities, help with guideline adherence, and provide education where it's needed and just additional ongoing support. So our Rural Healthcare Outcomes Accelerator was born in an effort to close that gap in rural outcomes, knowing that rural residents are at a 30% higher risk of stroke mortality and 40% more likely to develop heart disease. And they do live on average 3 years fewer than their urban counterparts. We wanted to be able to help address that. So our Rural Healthcare Outcomes Accelerator, we've got a web page there and a press release with some additional information. Like I said, we just launched this just a couple months ago, and the project period will go on for an additional 3 years. So when we look at the hospitals that are eligible for this program and that we'll be working with, it's any federally designated critical access hospitals. There's about 1,350 of those on the map there across the nation. And additionally, we'll be working with short-term acute care facilities that are located in a RHCOA classification of large rural, small rural, or isolated. That RHCOA classification is a USDA definition that uses census tract data to look at urbanization, population density, and commuting trends to work. So when we add in that definition, there's about 2,100 hospitals there on the map, many of which are located in Oklahoma. There's a great deal of opportunity there. So hospitals that meet either the critical access hospital definition or that rural short-term acute care facility, if they are then able to execute a new contract to get with the guidelines of stroke, CAD, or heart failure to their hospital's quality improvement programming, they'll be eligible to work with us for on our rural accelerator work. Just a bit more about those hospitals on the map, if you were to choose to join us. The impact there, there's about 60 million Americans that do live in those areas and receive healthcare services by those hospitals. The median bed size is 42, but we have critical access hospitals on the map with 4 beds, and we actually have hospitals on upwards of 500 beds because they're otherwise so geographically remote. The median annual discharge is about 1,500, just so you can kind of see. I mean, I know that many on the call here are likely on the smaller side of that, which is great, and actually a great opportunity to potentially look at all 3 of those clinical modules if that's not something you're already participating in, because there's typically lower volumes of patients, and sometimes the lower the volume, the easier it is to kind of look at all of those areas together. We do have a link there to the HRSA Am I Rural tool. So that Rural Health Information Hub, it's powered by HRSA data. And if you were to go there and type in your hospital's address, You can find out what your RUCA code and classification is. But again, if you're a critical access hospital, it doesn't matter what that is, you'll be eligible to participate. When we look at the cardiac and stroke specific mortality, so that earlier slide on the presidential advisory, it was depicting all cause mortality. We know cardiac and stroke are certainly big players in reasons for mortality, but this is specifically cardiac and stroke. And we can just see kind of those quartiles of age-adjusted death rates per 100,000, and just kind of highlighting Oklahoma there, that there's certainly a lot of opportunity, I think, to improve. We've got a lot of cardiac and stroke deaths, and a potential to really hopefully make a positive impact there. So those of you that are not familiar with Get With the Guidelines, I just want to give a kind of quick overview of what is it? Why would I choose to participate in this? Get With the Guidelines is the American Heart Association's healthcare-based quality improvement program. And what it really does is helps to ensure and provide support that the cares that are being delivered are aligned with our most evidence-based practice, our up-to-date guidelines, and those research-based guidelines, with the overall goal of improving patient outcomes. So Get With the Guidelines programs that are eligible for the Rural Healthcare um, Outcomes Accelerator participants are stroke, heart failure, and coronary artery disease. So stroke, there's over 7 million patients that have been entered in Get With the Guidelines stroke across the nation since the inception about 20 years ago. About over 80% of all strokes that occur in the United States go through a hospital that uses Get With the Guidelines stroke. Heart failure is one that it's aligned with our 2022 guideline for the management of heart failure. So we do have a recent update to that. And the nice thing there is that you're not left wondering or having to kind of piece together and ensure that the cares that you're providing are in line with the most evidence-based guideline. If you were to enter the patients into the tool, kind of get that measures check right away and find out, oh, here's where I'm, meeting all those measures, and here's some opportunity for improvement where I need to look at that guideline and kind of maybe alter my care or provide that to my providers. And then Get With the Guidelines coronary artery disease. So that looks at all of our AMI process data, and supports hospital quality improvement, but as well as that larger cardiac system of care. So we look at not only how are you doing, but how are you doing when working with your EMS, and then working with potentially the hospitals that you're transferring your patients to. So it kind of helps provide some feedback. It goes well beyond, all of these go beyond being a registry, and they really are tools to kind of help improve your care, provide not only patient education, but your own education and feedback as well. So how does Get With the Guidelines support your teams? You get that real-time patient level data reporting, and that eliminates any delays in performance feedback. You don't have to wait for maybe any kind of data harvest or any system or state to give you your data. You put the data in, you can run that report and see again where are your gaps, where are your places to celebrate your successes. The real-time benchmarking is really just a hallmark of quality improvement, being able to benchmark and be able to see not only what your hospital, how your performance is, how you're trending, but how are other hospitals like me doing? So you'll be able to see how are other Oklahoma hospitals doing, how are other rural hospitals, how are other rural hospitals of my size doing? Several benchmarks that are available to look at, again, to see, well, if maybe there's some areas where you're really succeeding, and that could be something you could share and celebrate. And then there may be some areas where you think, okay, we're a little bit below where others like me are doing better. How are they doing better? And you're able to kind of work with our quality improvement managers to help maybe receive some additional education and resource to kind of help improve there. So you get those data check-ins with our AHA quality professionals. We have our rural specific team, which we're very excited to be growing. So we've gone from 2 to 7 with this project, and most of those individuals have worked in a critical access or rural setting, either clinically or administratively. So I think it's really great to kind of have that additional support and look through that rural specific lens together. You can run raw data downloads. You can look at kind of in-depth analysis. Anything you put into the tool, you can get back out as far as data goes. So often hospitals find that this tool replaces maybe some manual reporting that's being done or manual data collection into an Excel spreadsheet, for example. This is really kind of providing a lot of efficiency and organization. And then you're able to create those spreadsheets if you'd like, or just run the reports that we have built into the tool that the vast majority of those hospitals that participate enjoy doing. And then we've got provider and referring EMS agency and referring and receiving hospitals reports. So you can kind of run based on an EMS agency or based on what provider. You can run those reports based on what provider saw that patient in the ED. So you can really see how are things going by provider or certain time of day, certain EMS agency that brings a patient in. So it just really helps to tailor the feedback, what feedback needs to be given and where does that feedback need to go. Like I said, there's point of care tools, there's patient education built into the tool, and then those feedback reports, which are really helpful as well, where you can just kind of one click and it creates just a nice, it kind of distills all of the care and shows a one pager of how did this go? Where did we meet the mark? And where did we maybe have additional opportunity for improvement? And those are things you can share within your ED or out to your EMS agency if they did bring that patient in. So looking at the benefits of the program, we've kind of gone over what Get With The Guidelines is. What hospitals get is they get no cost for newly enrolled Get With The Guidelines stroke, CAD, and or heart failure modules, and those will be covered until 2026. So you're able to get to use any Get With The Guidelines that you don't already use at no cost. So we're very excited to be able to provide that to hospitals. And at the end of that period, people always ask, like, are we obligated to continue? Is there any type of agreement there? And there's not. So hopefully you would use the tool, you would enjoy it, and in 2026 you might continue, um, by financially supporting it yourself. However, there's no obligation. So it's a great opportunity for, at this point, 3+ years to be able to participate and not have to pay for any of those modules that you may be adding. If you're a brand new hospital, you could add all three at no cost. So a really great benefit to be able to, again, really dive in and focus on that quality improvement. You get that enhanced rural QI consultation. Just a phone call, email away, you're assigned a rural quality improvement manager that would be able to work through the data with you, work through any, you might, how can I put this together to share with my quality team or with my providers? How can I share this data in a meaningful way? And that's really what we're here to help with. To kind of, first of all, is the data in there correct? How's the integrity? Are there any concerns with any clinical deficits, any areas we need to improve? And then how do you tell that story? We also have no cost access to our rural disease specific continuing education clinical modules. Let's say you are working with your quality improvement manager and there's a couple areas on heart failure that your hospital's not, really having some gaps and really had a lot of opportunity there. You can look at those clinical modules and maybe assign them to your staff as you wish and share them with your nurses or your providers. And they're free, they're on demand, and they get continuing education credits, and then they get education on potentially, hopefully, improving some of those areas of opportunity. So those will be available if you choose to participate in stroke, CAD, and or heart failure, whichever disease area that you choose or areas that you choose, you'll have access to each of those clinical bundles and all of the content that's inside of those. You also get complimentary access to our AHA professional membership. So we are waiving the fees for 2 general professional memberships each year for each site that participates. That general professional membership level provides the ability for someone to join AHA Scientific Council, to get some journal article access, get some discounts on some scientific conference and meeting registrations. And then I think one of the great benefits is you get access to last year's virtual offerings for scientific sessions, our cardiac conference, and international stroke conference. So you have access to kind of the latest and greatest science research, anything that's been shared at those. There's several of them come with continuing education as well. It's just a really great opportunity to have additional education and content that can be really helpful for you. We will have AHA facilitated stroke and cardiac rural learning collaboratives throughout the project period as well. So on a quarterly basis, we'll be meeting, kind of convening these groups together in our rural cohort to talk about the updates, look at the aggregate data together in the rural cohort, be able to see, how things are going, where can we, pat ourselves on the back, and where can we continue to focus. And then we are developing our AHA Rural Community Network as part of our larger AHA Healthcare Network. You're able to get on there and kind of connect with peers, connect with clinical content experts in that space. And what I'm really excited about is we're housing order sets, clinical decision pathways, some clinical quality improvement tools that other hospitals, other systems, other states have put together and are using successfully. And it's going to be a great place to go on and maybe as you're looking to kind of revamp maybe an order set that you're doing, or look at how are other places, you know, um, succeeding in this area that we're having so much trouble. You're able to go look at these other materials and maybe model off of, pick and choose what works for you, and rather than starting from scratch and reinventing that wheel. And then we've got AHA recognition and marketing toolkits. So we have recognition toolkits available for hospitals that do earn an award. So based on their performance, if they earn, um, that award on, being kind of above the threshold on each of those clinical areas, we've got that national marketing. You're included in our U.S. News and World Report Best Hospital Edition. But even those that are just participating in the accelerator and choosing to do so, we have professional marketing toolkits available that you can share out with your community, just your commitment to excellence, your commitment to growing, that quality improvement, and to that the commitment to excellent care every patient, every time in these areas. When we look at Get with the Guidelines, it does come with a recognition component, but we have a rural specific recognition that we're launching to really bring equity into that space, which I'm really excited about. So the next few slides kind of go over what those measures look like, and they're content dense slides, so I will not go into detail, but again, you'll get these slides after the fact, so you can look at all of that. So if you join us and you're working with stroke, CAD, and or heart failure, you do get the full program. You're not getting any dilute form of the program. You get the program to be able to work through and use it as robustly and comprehensively as you wish. Everything, if you're familiar with Get with the Guidelines, you get the standard, nothing goes away, but you also get this rural acute bundle that's added on, and you get to look at this on stroke and CAD. We're working on one for heart failure, but I'm showing you here the rural acute measures for stroke, and then we'll do so for CAD as well. So these are in addition to really everything that's already in the tool. But what's exciting about these rural acute stroke measures are that they apply to really every patient every time, regardless of discharge disposition or length of stay. So if you are at all familiar with Get with the Guidelines, you've used it in the past, or been somewhere that has used it. Our traditional measures, we have 11 measures, only 4 of them are acute measures. So if you transfer all or the vast majority of your patients, you're really only typically seeing patients in 4 of those measures, and you're not really eligible for our national recognition. We're changing that this year. We're bringing a lot of equity into this space by, understanding maybe a rural hospital, especially a critical access hospital, may only have 2 strokes, 10 strokes. It may be a small number, and I think that when there is a small number like that, it's really, really important. When you don't see them every day, you see them once a month maybe, or even less often. It's really important to have that process down and to be able to treat that patient well and meet all of these guidelines here on the screen when you do see those patients. And then we want to be able to celebrate that and be able to fairly recognize you for that hard work in that acute space. So we have brought this rural stroke recognition to to the forefront here. We'll be having an inaugural recognition year in 2023, and then we'll kind of grow that from there and be able to hopefully with these longevity based awards be able to kind of grow hospitals from bronze to silver to gold. So when we see these measures, we also don't have any individual measure requirement. So if again, you may only see 3 strokes in a year, and if on one time, you didn't get the door to CT within 25 minutes, you would, it's okay if you're below 75%, as long as you're kind of making up for it in another area. So 75% composite is what we're looking at in order to be eligible for recognition. So again, we'll share this with you after the fact, so you can look through those. And if you have any questions on any of those measures or some more detail of those measures of what patients might be included or excluded, I'm happy to answer that for you at any time. And then on our CAD side, we have the same thing that's rolling out here in January. So when we look at our patients, our ACS patients in the rural space, I know that we do have some hospitals that have a cath lab. Maybe it's not 24/7, maybe it is. But this is really aimed at those patients that are referring on. So when you don't have a cath lab, this is really pertaining to you, or when your cath lab is not open. So we're looking at those STEMI patients. Whenever we have a STEMI, we want to get that 12 lead within 10 minutes of arrival. We want to notify that next hospital that the patient is going to be transferred. We want to give the appropriate medications before we transfer. We want to get that patient out as quickly as possible. So we're looking at those measures on STEMI, 75% or greater in composite. We want is our goal. And then we also have the ability to enter your non-ST elevation ACS patients. So those ACS, those maybe unstable anginas, but also the non-STEMIs. What we're really focusing on in this group is the risk stratification. So the identification, get the ECG, the cardiac troponin done. We want to risk stratify these patients. We're going to be pushing and educating on the heart score, but you can use any other, scoring methodology. There's several options in the tool that you may use. But what we're really using the heart score for is to help hospitals to keep the patients that they should be keeping, to keep those low risk patients, keep the intermediate risk patients, provide those cares, and then get them the appropriate follow up. Get them a follow up appointment or cardiac testing if it's indicated. And then those high risk patients, we want to make sure, yes, this is a high risk patient. We want to anticoagulate them. We want to get them out as quickly as possible so they can have potential early intervention with PCI. So we are looking at when a patient or a hospital chooses to participate in Get With the Guidelines CAD, they can choose to enter just their STEMIs, or they can enter their full ACS population. So it gives you a little bit of freedom there to choose. And sometimes hospitals say, well, I'll start with STEMI and then maybe see how that goes, and then maybe start to add the ACS patients after, kind of a ramp up period and they're feeling a little more comfortable. Heart failure, we do not have a rural specific heart failure recognition program yet. We are working on that. But heart failure works really well as it sits for hospitals right now, really of all sizes. So if you're keeping a heart failure patient, a heart failure exacerbation, or a primary diagnosis of heart failure, we're really looking at these 4 measures on the screen, every patient, every time. And then that we've got quality measures down below and a target heart failure measure set. So we kind of have, again, a place to grow the improvement efforts around heart failure. So kind of first focusing on those 4 measures and then looking at maybe improving on some quality measures and those target heart failure measures over time as well. So as a participant, kind of see everything that you get, kind of see the measures that we're looking at through Get With the Guidelines. So there's, what do we expect of a hospital that participates? We would have a hospital sign an agreement to participate specifically in the accelerator. And that's that, here's all the benefits you're getting. You're getting the no cost Get With the Guidelines. And then, you're agreeing to participate with us and to enter the eligible patients. We're waiving the cost of any new Get With the Guidelines module, but in doing so, we just want a hospital to reasonably enter the data and to stay up to date. We, obviously things come up, turnover happens, all kinds of things happen, which we certainly understand. We just want to have you working with us and communicating with our quality improvement manager when things do come up. So a hospital would complete that agreement, and then they would also enroll in stroke, CAD, and or heart failure, whatever they're not already participating in, whatever they choose to participate in, by completing an agreement on there. So you'd have your rural agreement, and you'd have that Get With the Guidelines agreement. And again, you'd agree that you're gonna use the tool as it's intended. You're gonna enter the patients that, whichever category we're talking about. You say, I'm gonna do CAD, I'm gonna just do my STEMIs. We'll agree to that, and then again, you have the option to add or to continue to collect ACS patients in the future as well. And we also then would want you to kind of designate at least one hospital team member that would be attending those rural learning collaboratives, have access to the Rural Community Online Network, and we want you to name those 2 that get the AHA professional membership. So we know we have those quarterly learning collaboratives. Again, understand if people can't make them every time. We know that you're wearing 101 different hats every day. But again, it's just just communicating, agreeing to communicate with the rural quality improvement manager to just say, can't make it this week, not a problem. They'll share the information with you after the fact and hope to see you on the next one. So kind of my final slide, people always wonder, what does this look like? If I'm using it with the guidelines and I'm not familiar with this, how long does this take? What is this, data burden? I don't have time for one more thing, which we certainly understand. We really are looking at, when we look at the numbers here on the screen, we're looking at rural hospital averages. We invite our rural hospitals to use our limited data collection forms. It's still collecting everything you need to ensure guideline-based cares, but just not in the as detailed of a fashion as our standard forms. As a participant of Accelerator, getting all of this covered at no cost, you certainly are welcome to use the full forms. Those are available to you. There's no cost for that. But typically, especially in the critical access and small hospital space, they find that the ratio of time in to value out is really best met by using those limited forms that collect about 35 to 40% fewer data elements. Just a little bit easier to get the data in. You still get a lot of great value and helping to kind of identify where you need to improve. But when we look, most small hospitals use direct data entry, so they are just entering that manually. And just as an example, I put in, if you have 40 stroke cases, maybe about 2 hours a month is what you'd be using your time entering these patients. So, you're probably or hopefully already tracking some of this data in some way. So rather than having to spend whatever time on creating a spreadsheet and color coding that and ensuring that everything is up to date, instead of doing that, you could enter in to get with the guidelines, have all of those that the guideline applied for you, ensure that everything is pass or failing, it's all there in adherence with the most current evidence-based guideline. And then again, you could generate spreadsheets or reports from that directly. So just you can kind of get an idea of what that looks like. I'm happy, this is a calculator, so you can type in your own after the fact, or I'm happy to kind of talk with you a little bit more about what that might look like for your facility. So I will pause here. Really appreciate your time. I do have a link to our Rural Get With the Guidelines support team. So if you have any questions or you want to again, check your hospital. Are we eligible, or is this hospital we work with eligible? You can always send an email there. I do have this link to our contact for more information. So if you say, yeah, this sounds great, we want to sign up, what you would do is contact there. You put in just your hospital's information, and then our project manager would get you set up with someone from our rural health team who could share the details and get your specific hospital signed up. So again, I will pause. I really appreciate your time and happy to answer any questions that anyone does have.
Thank you, Katie. Does anyone have any questions real quick? All right, well, that was a lot of really great information. We did record this session and I have Katie's slides. I will send both out once the recording is posted. If you do have any questions, please let us know. Again, Katie, thank you for your time, and everyone have a great weekend.
Thank you.